Well, good morning, good afternoon, good evening. Welcome to the latest episode of If Data Could Talk. I'm your host, Andy Cotgreave, Technical Evangelist at Tableau. Today, another special segment for you. Last week, my colleague Steve Schwartz interviewed Jeremy Schubert from Abbott Labs, talking about testing data and testing in general during COVID-19. So during that discussion, they're going to go into the details of testing, not so much about data viz. So if you are looking for your data visualization fix and looking for something around COVID-19 testing data, I recommend taking a look at this visualization created by my friend and colleague, Sam Priddy. He's looking at how testing data is being used across the US. This was a featured viz on our COVID-19 data hub. So we'll add a link below. Go take a look. It's a really good piece of work. And with that, it's over to you, Steve. Take it away and tell us about your guest.
Hi, everyone. Before we go to my conversation with Jeremy, I want to take a moment just to mention we recorded this interview last week, the day George Floyd was murdered in Minneapolis. And before we saw sort of a nationwide gathering of folks really standing up to the kind of systemic inequities that have plagued the African-American community for a long time in this country. If the conversation doesn't seem like it has any awareness of these events, it's because at the time we didn't. But this relationship between mass gatherings and COVID-19 and what it means from a testing and data perspective is something that we're going to keep looking at and think we'll be having conversations about for a while. So please keep that in mind. Nothing was a function of omission as much as just timing here. So thank you, and I certainly hope you enjoy the interview with Jeremy. I'm Steve Schwartz, and today I have a great opportunity to chat with somebody whose work really is at the heart of what so many of us in the data community are thinking about right now. It's shaping our understanding of COVID-19 and how it's spreading, and also what we do and don't know about what life is going to be like as we get back to work and some sort of normal. Today I had the pleasure of chatting with Jeremy Schubert from Abbott. For those who aren't familiar with Abbott, it's a company that creates products to help people live their best lives through better health. Jeremy is the divisional vice president for U.S. Abbott Diagnostics Division and Commercial Operations. And right now, they are developing technologies and expanding access and sharing resources to provide support during the pandemic. And I'm thrilled to have Jeremy sharing his time with us today. Welcome, Jeremy. As an introduction, can you tell us about the current state of testing today in the U.S. and what the data is and in a lot of ways is not showing us about the current status of the disease?
Okay, thank you. And thanks for having me. First, it would take maybe a bigger picture kind of look at the situation with this pandemic. Kind of the first thing is to think about is that the pandemic and COVID-19 is more than a healthcare problem. It's a public health problem that impacts and is impacted by healthcare and healthcare systems. And thank God for our great healthcare systems and the personnel we have, because they're doing outstanding work. Second, what makes the work they're doing more impressive is that pandemics are not kind of our day-to-day life in U.S. healthcare. And although we have some of the world's foremost experts in terms of infectious disease, pandemics are not in our collective wheelhouse. And this is challenging our health systems differently. It's challenging them to think differently. It's challenging them to act differently. And that's what's creating a lot of buzz around COVID-19. Third, and this is perhaps most important as you start to think about the juxtaposition of pandemics versus acute care, it's that health is more than physical well-being. What most of us know about health and healthcare is we get sick, we get better, and it's surrounded in kind of this physical domain. But if we really take a step back and look at what do we mean by health, health is physical, but it's also mental and social, emotional, sexual. There's a number of domains, that surround health. And if you have a kind of a question about that or kind of squinting at that domain, you just have to ask yourself, for your children, your family, would you want them to be physically fit and emotionally poor? And the reality of life is we all want to be treated and be thought of as the whole person. And that's going to be really important as we start to think about the impact around COVID-19 and what's happening with our healthcare system, what's happening with our population, and kind of how we need to attack it. So as we kind of move into the state of affairs with COVID, I'm a public health professional by training, and effectively there's pandemic 101 that they teach you when you first start, which is you can't fight what you can't see. And that really typifies kind of what's happening with COVID-19 right now, is really being able to see what's kind of happening with the pathogen, how it's spreading, who has it, and what kind of impact it's having on the health and well-being of those individuals. And so the fact that there's kind of this invisible transmission that's happening with subclinical people makes this a challenge. Now, we know in healthcare that effective treatment begins with an accurate diagnosis, and that makes a ton of sense. Is you're gonna treat somebody based off of what the data is telling you to do. Well, pandemics are kind of the same, right? An effective pandemic management begins with a clear and broad understanding of the state of the pathogen, but what's important is at any given point in time, because it changes. And so this has to be underpinned by a consistent, continuous, and insightful use of epidemiologic, social, and clinical data. And so when you wrap all of that up in a box, to answer your question, is really kind of the state of the affairs is really evolving. And I really can't tell you clinically where we are, because really there's more data that is required, beyond the testing that we have, and really beyond just testing, for us to get a really good sense of what all of this really means. What I can tell you the data says is we have rock stars in our healthcare systems, and we have people that are doing tremendous work. And our healthcare system, despite what a lot of people would have you believe, has done a nice job of responding. We have health systems that prepared for and even were able to avoid surges that created massive problems. That's not to say that there weren't challenges, right? But it is to say that the data tells us we've had pretty good response by our healthcare personnel, working against this disease. And so it tells us we can feel really good about our ability to manage an acute and chronic situation and respond in a crisis. What the data also tells us, and this may be a bigger picture thing, is that there are huge opportunities for us to better leverage things like social determinants of health, lab expertise, and other things in clinical care into the public health domain, and to be able to apply to this larger definition of health, particularly when it relates to peace of mind. Now, we were talking to an executive in Chicago, or one of the largest health systems in Chicago, and his position was quite interesting. It was that fear is actually more impactful than the virus itself. And let's think about that for a second, because that's not to minimize or marginalize the physical implication that this virus has had on the lives of many, right? It has really been impactful. But it affected a much, multiple number of more people, just from a standpoint of fear. And, if you want to kind of translate that out into learning about the impact of COVID-19, you don't have to look any further to the degree of people that are deferring their care. In some of the interviews we've done with senior executives of health systems across the U.S., what we consistently see is the number of heart attacks and strokes that have been coming through their ERs are down. Now, people didn't stop having heart attacks and strokes. They just stopped showing up to the ER. And I don't think we're fully going to understand the massive impact that this has had, not just directly from those who've experienced or had COVID-19, but for those whose lives are being impacted by the fear, the deferred care, and the inability to live the full life that we all hope for ourselves and for our families.
That's fantastic. And, as you put it, there's so much we don't know about the disease. But again, you're also talking about systems, and there's actually so much we don't know for a lot of us about the systems for testing. Truthfully, I think our exposure is something that happens at our physician's office or maybe a home pregnancy test. Right now, not a lot of us have experience with COVID testing. So could you take a minute and take the viewers kind of behind the curtain and tell us, what does it really take to do the testing for a disease like this? And then how does that scale up?
Okay. Well, I'll talk a little bit about the process, because, the interesting thing about it for all the viewers is important to understand that testing is not one thing. A lab test and lab testing is really multidimensional. Now, as it relates to COVID-19, I'm going to simplify this into a basic 2x2 matrix, but this is really oversimplifying it, right? Because you have some testing that's aimed at testing the virus, and you have some testing that's aimed at testing the antibodies, or, to be able to understand if somebody's had the virus, and with the hope that, that'll tell us a little bit more in the future about immunity to the virus. So you got that domain of whether you're testing the virus or you're trying to find antibodies. And then you've got these locations of testing where we could either do it point of care or near patient testing, or we do it at a central lab somewhere. And I'm going to kind of focus on the process of how it would be done at a central lab, because there's a little bit more invisibility, so to speak, to the complexity that's associated with that. Yet the processes of these steps are pretty much very similar across the domains. And again, the work is actually in the pre and post analytic. It's not actually the processing of the sample in the instruments. It's actually all the work that's done pre and post that creates most of the dynamic in the testing. And again, why our healthcare workers and our lab professionals are so important. Now, what I'm going to walk you through is something we call the diagnostic cycle. So kind of end to end, what happens? Kind of in step one, you have this patient entry or patient recruitment. And although that may sound like, okay, that's a nominal element, when you start to think about what we're trying to do from screening and a population health perspective, kind of one domain of finding the people and getting the people to the testing is kind of an important element, particularly when you consider things like social determinants of health, where maybe somebody doesn't have transportation, or as I was mentioned earlier, there's deferred care where people are afraid or concerned to come in and be tested. So you've got that domain. And then we have the next step, which is ordering a test. Now that we all wish it was just a magic wand of pushing a button, but there's a lot more to that. We have to draw the blood or take the sample on a swab. Then there's a degree of documentation that has to take place in a computer system to kind of load the ordering and what might be done. And then we have to label the sample, whether it's a tube or the swab itself, where we have to put a label to make sure that that's gotten done. Then you move into kind of transporting that into the lab, where we have sample receipt. And this is where it gets behind the scenes, but where there's a lot of work that gets done. If you think about the thousands of samples that might roll into a lab at any given time, where they have to unpack the samples. There may be some additional data entry that's required to ensure the samples were received, or some additional data is supported to it. Then the samples all have to be sorted, because there's not just one universal box that everything runs through. There are different departments that may be on different floors, that may be in different buildings, and for sure run on different instruments, where the samples have to be sorted, maybe even multiple times, to be able to put in a position where they can be processed. Then samples have to be prepared appropriately. And so, what this might be is we might have to centrifuge a sample, or we might have to treat a sample before it's transported to the instrument, and then it's loaded. Then you have instrument readiness, right? So instruments aren't just always sitting there, ready to go, like maybe a laptop computer that you leave plugged in all the time. So there's a startup element to it. There's maintenance. There's quality control that may have to be run to ensure the instrument's ready to process samples, and then we process. Once an instrument's done processing samples, there's a phase of in-lab analysis that takes place. And what happens here is your laboratory professionals are actually validating the results. So they're making sure that the results they're seeing coming off the instrument are consistent with the quality control that was done, and are reflective that the instrument worked appropriately, and we feel comfortable that the results are there. There may be some additional steps in terms of calling a physician if there's a question, or provide some information, and even moving into rerunning the sample, or maybe even reflexing to another test, given what the result of the sample is. And then there's a release of the result. Now that could be done automatically, or it could be done manual across all this continuum. There, the lab generally has to manage the sample in some way. So they have to recap, or control the sample, and generally will store it for a period of time, or in some cases we'll just dispose. And then beyond that, there's additional interchanges that happen between clinicians and patients. And it's a pretty broad and robust process, but it's one of those things that when you take everything into consideration, this isn't just about how many instruments do we have, in the U.S. processing any type of testing. There's a huge amount of human intervention, and even though we may have excellent automation and process flow, if you have a surge of volume, any good process can be outworked by the amount of volume that you put through it, and that can be challenging. And so some of the things that are genuinely affecting the health system's ability to process samples in this testing, not just the amount of equipment that they have or the amount of tests that are available, but just being able to integrate this type of work into their day-to-day workload that they already have.
Yeah, it's fascinating that it's about measuring far more than just the physical infrastructure, but also really the human infrastructure. And as I understand it, these labs are not always close to where the samples are being collected. And sometimes you're moving them short distances, sometimes much longer distances, and there's a lot of logistics in data make that process work. But at the same time, we're all hearing about how we need however millions of additional tests to be approaching something normal. As you look at this situation from your unique seat, I kind of gotten the impression that you think functionally the capacity is likely there, but do you feel like we're moving in that direction at an appropriate speed?
Yeah, I mean, I think we are, and maybe you talk a little bit about kind of that capacity domain, because like you rightfully say, there is a degree of complexity and it's multifaceted for us to be able to do that. And again, trying to think through, the different dimensions about each of those types of tests and what's required. And let me kind of pause here, because I think kind of adding to that is, I would express that the FDA has done a very nice job of flexing to create the opportunity to scale testing and to enable testing to get done at speed, at scale, in the right locations. And again, as we start to think about capacity, we have to go back to that kind of 2x2 simple, multi-dimensional framework I had earlier, because what you have when you start thinking about capacity with virus testing, it's different than what you think about when you think about capacity with testing for antibodies. And also it's different when you're thinking about point of care to lab. So let me talk a little bit about, separating at least virus and antibody testing a bit, to kind of talk through what we're looking at here, because they are very different capacity issues. From a virus testing perspective, there are some capacity constraints that we're working through. And again, it's a multifactorial problem across the U.S. One of the interesting things that is often underlooked is the fact that there's the immediacy of the answer, right? So how quickly do we want the result? Because then that affects kind of the location of where we want to do the testing, and that can affect the patient pathway of how quickly we can move patients through the system, give them an accurate diagnosis, and move on. And when you're dealing with virus testing, speed matters to a degree, and that's this speed and immediacy that also creates some anxiety and angst in the system. When you start to deal with virus testing, you also have alternative collection modalities beyond just a sample tube with blood, which much has been made about swabs and things like that for collection. And so when you start to think about these other inputs that are part of the testing, they become part of the supply chain, which creates scarcity and then again creates capacity constraints, because the capacity is more than the test or the instruments or even the people. Sometimes it's an input to the testing itself. Generally speaking, for the instruments that run this virus testing, generally they're molecular platforms, and these instruments operate at a lower number of samples per hour and samples per square feet used in a lab. So they can take up a lot of real estate, and not generate a high number of volume at the same time. And if you can think, these are sometimes more of a manual process orientation versus automation. And so when you kind of pull those things together, it does create an environment where there is some constraint, and it may not be pure ability of instrument capacity to generate numbers. It can be any one of these elements that might break down or might be the bottleneck And again, across any geography, it could be one or the other. And so it's a really complex, problem to understand. What I can tell you is across the U.S., manufacturers are and with the support of the FDA are diligently working to scale up. And I think it's going to be a kind of a short-term issue as it relates to this because of the great work that's happening, across all the stakeholders within our healthcare system. So the scale is moving quite quickly. And also there's development of kind of some alternative modalities for capturing this immediacy or measuring the virus, like the development of antigen tests, which again are going to facilitate easing some of these capacity issues. Now, separate when it comes to antibody testing, in fact, actually, there really isn't a capacity constraint. Again, because of the type of testing that it is, because of the automation that's used, because that's more in the norm of what's happening in a lab from a day-to-day perspective. So, there's plenty of capacity to process antibodies. For institutions, there may be a capability constraint, as they may not have the instrument or the technology currently to run the test, or maybe their prime vendor doesn't actually have the test yet, but they're promising to bring it up eventually. But the reality is, from an antibody perspective, there isn't a capacity constraint.
I want to follow up on something you said earlier about the data, and if the data that is publicly available accurately reflects where we are. I know that there are a handful of initiatives that are doing their best to track testing rates across the country. For your average analyst who's starting to get into this testing data, any insights, guidelines you'd offer in terms of what's being reported and maybe how much we're not necessarily seeing?
Yeah, so let me answer that kind of in a couple domains, because again, as we look at this, there's the data kind of bridges between a kind of clinical diagnostic domain of, okay, here's how many people have been diagnosed, here's how many people have been treated, here's how many people have hospitalized, here's how many people have died, here's how many people have recovered, thank God. So you got this kind of these kind of episodic points, right? And a lot's made, and when you start to get into, and this is broader in healthcare, but particularly here, about the quantity of data, right, that we have, and we need more data, we need more data, we need more data, and that's interesting, and for sure we do need some more data and some different ones, but sometimes that leads us in a healthcare position to actually doing a lot of data warehousing, which is again interesting and maybe useful, but not all that impactful when you want to have quick response, to a problem like this. And so the concept we always like to try to focus on is more data mobilization, right? And so more specifically, how do you get effective at driving insights from the data, actions from the data, and then effectively learning from those actions, which is in fact new data, right? That what we've learned. And this is less about kind of data points, and it's more about this artful combination of technology, people, and process, and that strategic, clinical, and operational process. To be more clear. And so it's about pulling those things together. So the challenge is not necessarily more data. The challenge is not necessarily technology, and we have tons of technology. It's that intersection and integration of those other things, of the people and the process, to be able to consume it, to mobilize it, meaning driving insights and actions and learning. And so those are the things that I think is people who are starting to walk into the data field, being able to have data, warehouse it, even visualize it is interesting. Where impact starts to come into play is when you can start to address the people and process side of it, where that data starts to move, starts to make impact, and starts to create learning. And I think that's where the focus needs to go.
That's great. And I got to say, you've been extremely generous with your time and really appreciate it. I want to conclude with this, from your seat, as you look out at the next couple of weeks, next couple of months, what are you thinking about? What are you keeping an eye on?
Yeah, so I think what we'd say is we're as a country and as a health system, we're going to evolve, and we need to migrate a little bit to being able to manage the public health, not just deal with the clinical ramifications, the acute ramifications of the virus. And so I think where as we start to move forward, what you're going to see is we're going to move away from a simple system where we're treating patients and reporting the number of patients that we're treating into to something that is much bigger, and I think over the long term is going to create a lot of value for our health system and the well-being of U.S. citizens. And so I think it's best not to think about this kind of just as simple reporting or processing, but rather than think about it almost kind of like a radar system, right? Where, and I'm going to call it a three-dimensional radar, because we're going to take the testing information that we have, and there's been a number of services that do a fantastic job of collecting that information and sharing it. But taking the testing value, taking effectively the geolocation of these of positive results, or where we see kind of the virus moving, both past and present. And I have to factor in past because it's important to understand from a contact tracing, where somebody's been, but also combine that with social determinants, these social environmental factors that kind of affect somebody's well-being, because the data would suggest that there's the social determinant side of this problem as well. By combining this thing into kind of this three-dimensional radar, what it's going to help us do is be in better control of what's happening with this virus and be more effective in stellving it from transmission and bridging to where we can have vaccines or better treatments along the way. And I think at the end of the day, kind of the important element of that is, and done in the right way, can build a ton of confidence for the population about their well-being, and can take away a lot of the confusion, the worry, the concern, which at the end of the day is weighing heavily on many of our communities. And by doing that, it's going to get us to a quicker return to life, and maybe it'll be a different world, but a world that from a healthcare and public health perspective will be better.
Okay, thank you again, Jeremy. Really appreciate all the time you spent with us today. Hugely informative for all of us as we think about where we are, the data that's all around us, and what comes next. So with that, I'm going to pass it back over to Andy, and we can wrap up the episode.
Awesome. Thank you.
Okay, well, thank you, Steve and Jeremy, for a fascinating conversation. I know I always love hearing about what's going on behind the scenes in these big data operations. If you want to find out a little bit more, we've got links below. Also, go check out the curated gallery of great work being done by Tableau customers and users from across the globe. We would also love you to follow us on social media and tell us what you think of this conversation or the other conversations in the series. Also, are there any customers or stories or data episodes you'd like us to cover? Well, that's it for today. Wherever you are, stay safe. Thank you for watching, and we'll see you next time. Thank you. Goodbye.